Okay, it is 5 p.m., so I will now call to order this special meeting of the Shawnee Mission School District Board of Education. The first item on our agenda is the Pledge of Allegiance. Would you please join us in the pledge? I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Our next item is the adoption of the agenda. I'll seek a motion to adopt.
So moved. Goodburn.
Second, Sinclair.
Thank you. All those in favor, please say aye.
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 Are there any opposed? Hearing none, that passes unanimously. Our discussion item for this evening is the 2021-22 Semester 2 Mitigation Plan. When we passed the mitigation plan in November, we had said we would watch the transmission rates, and that one of the factors taken into consideration was that elementary students would have the opportunity to be fully vaccinated by January 3rd. And over the course of the last week or so, transmission rates in our community have gone up. And one of the factors with regards to vaccination is that 12 to 15-year-olds who have not had access to a booster are now considered to have significantly waning immunity and are not protected by the shots that they had in May. So there are two factors that have changed since November, and we are here to discuss tonight some of the other issues going on. So we have two guests this evening. We have Dr. Elizabeth Holshoe, Miss Elizabeth Holshoe from JCDHE, and Dr. Melick, who is with the American Academy of Pediatrics Kansas chapter. And I think what we will do, or what I will do, is I will turn it over to Miss Holshoe first so that she can give us kind of a summary of where the county is at. And then we will give Dr. Melick an opportunity to introduce herself and give us a brief recap of where maybe the pediatricians are at. And then we will open it up for board discussion for board members to discuss what we've heard, and then also to ask questions of our two guests this evening so that we can get additional information if we have questions. So with that, I will turn it over to Ms. Holshoe, and thank you for joining us this evening.
Thank you. Thank you, board members, for having me. Again, it feels like every time I come here, it's never good news. And today is no different. And in fact, in the last week or two, things have changed dramatically in our community as we've watched what's happened in the rest of the country, particularly with the Omicron variant circulating. As you all know, at the end of November, Omicron was first identified in South Africa, and since then has spread throughout the globe very quickly, being identified in at least 110 countries. Omicron is very different than Delta or any of the other variants that we've had previously in a number of different ways, in some ways slightly better, in other ways not. The primary being that it is far more transmissible than Delta was, and if you recall, Delta was more transmissible than Alpha, or the wild type virus that came out of Wuhan, China, in late 2019. Omicron is as transmissible or as infectious as measles, which we have found to be one of the most infectious viruses known to humans. And
we are here to gather information. Please do not interrupt our speakers.
And what this means is that we are seeing unprecedented numbers of cases, again, both locally as well as throughout this country and throughout the globe. Over the weekend, from Thursday when we updated our dashboard last until today, we had over 2,000 cases, which we have never had before. This morning, just from 7 a.m. until noon, we were already at about 1,000 cases.
We aren't interrupting the speakers. They are providing us with information that we need to make decisions tonight. We will adjourn this meeting until people can be quiet if we need to. I am prepared to adjourn this meeting at this juncture until this room can be quiet so that we can get information from experts. I am prepared to adjourn this meeting until we can keep this room quiet so that we can get the information we need to get from our speakers. Okay, we will adjourn for the next 10 minutes, and we will reconvene at that time.
Have to get the information, truthful information in that 10 minutes.
So we are reconvening right now. If we have an additional interruption, we will adjourn again and then reconvene when we are able and live stream it at that point. So if there is an additional interruption, we will adjourn again. I am going to turn it back over to Dr. Holshoe, or Ms. Holshoe, sorry, I'm getting my doctor and my miss confused. And please continue.
Absolutely. So I believe I was talking about how Omicron is different in that it is more transmissible and equally as transmissible to measles. While there are some positives with Omicron, in particular that it appears to be less severe, causing a smaller percentage of individuals to end up in the hospital. And given our current status in our hospitals, if you hear any of the local hospital chief medical officers speaking, they're all sort of on the brink. That is good news. However, because Omicron is so much more infectious and can infect so many more individuals, we still run the risk of overwhelming our healthcare system just again by the sheer volume of people. So if you have a much larger number of individuals infected, even a small percentage becomes a large number when we talk about our hospital systems. As I said, this has caused us to have a higher incidence rate in Johnson County than we've ever seen throughout the course of the pandemic. As of today, our incidence rate is 637 per 100,000 residents. To give you some context, even at our height last fall in November and December, when we were talking about what we were going to do, we were only at about 4 to 450 per 100,000, and now we're at 637. Additionally, our percent positivity, which indicates both the level of transmission in our community as well as the availability of tests and the number of individuals who are getting tested routinely, our percent positive today went up to 21.5%, which is probably double what we had ever seen thus far in the pandemic. We are seeing this play out in our daycares, which were already being hit by Delta, and we are seeing a large amount of transmission there. And with Omicron in the last week or so, we are continuing to see cases being reported at an increasingly quick rate, both in terms of individuals becoming positive as well as transmission within classrooms. So all of this to be said, what we're looking at is very likely a rough couple of weeks. 4 to 6 weeks is what the current predictions are. Omicron, because it is so transmissible, and what we've seen from other countries, including South Africa as well as the UK, that should peak pretty quickly and then come down. But we are looking at about 4 to 6 weeks of this peaking, probably mid to late January. And in that time, public health will be overrun. We cannot do case investigations on 2,000 cases or 1,000 cases a day. We do not have the capacity. And we also are concerned about how this will impact, again, our daycares, our school systems, as well. The other piece of Omicron that makes it a little more challenging is that it is able to evade the immune system better than other previous variants. So in particular, people who have been previously infected, so say they had Delta or even Alpha or the wild type virus before that, they do not seem to have really any immunity to prevent an infection with Omicron. Additionally, with vaccines, it's been shown that 2 doses of the mRNA vaccines, so either Pfizer or Moderna, are only about 35% efficacious against Omicron infections, although with the booster, that does increase substantially. And so when I think about what this looks like as we move into spring 2022, we are in a very different place than we were last year with vaccines being widely available. Unfortunately, those, of course, under the age of 5 are still unable to be vaccinated. But we have highly effective vaccines, particularly when individuals are boosted. However, with the massive amount of transmission that we're seeing and the number of individuals who are vaccinated, particularly those without boosters who are getting sick, it is certainly a concern. Additionally, last week, on Monday, the CDC updated their isolation and quarantine guidance, reducing it to 5 days. So for an individual who tests positive for COVID-19, they are to stay home for 5 days and then subsequently mask for another 5. And the same for individuals who are exposed, who are unvaccinated, or who have yet to get that booster and are beyond that 6 months of time. Individuals are recommended to quarantine for 5 days and then continue to mask for an additional 5. I think for public health at this moment, we are definitely bracing along with our healthcare partners for what is coming. The infections are incredibly widespread in our community right now, and we anticipate that those numbers will only continue to go up, which will impact employers, schools, daycares, and really every part of our community, just given the sheer number of individuals who are ill with COVID-19.
Thank you. Dr. Mellick, I'd like to give you an opportunity to introduce yourself to the board, and then if you could just provide us like maybe a brief summary of the experiences that our pediatric offices are facing right now. And then
Sure.
That would be great. Thank you.
Can you guys hear me okay?
Yes.
Okay. So I am Dr. Jennifer Mellick. I am a board-certified pediatrician and practice in the Johnson County area of Kansas. I've been practicing for about 17, 18 years now here, and I am on the board of the American Academy of Pediatrics Kansas chapter. I was a past president, and I guess what I'd like to share about what the pediatricians all very connected through social media, through group chats, is that we are very tired. This entire pandemic has been very difficult for us. What our goal has been is always to just take care of our patients as best as we can, to keep them as healthy as we can, because children are the future pretty much of everything. And we're overwhelming the healthcare system. I'm an outpatient pediatrician, and children have been less affected by this pandemic medically than adults have been. But that doesn't mean that my staff is not having to vaccinate 2 to 3 times more than we usually do this time of year. Usually this is our big flu vaccine time of year, but we're having to do COVID vaccines and boosters. And we're doing that not just for our patients, for their parents, because we know that caring for our patients is best to care for the whole family, because that's who raises our children. But my staff is working overtime. We are constantly trying to keep up with our well child checks, because these children need their other vaccines. And we are just seeing so much sickness. Last year was such an anomaly for us, because we did not see flu at all in the last flu season. This year was very different, and has been very different. Last year I would see well visits in December, January, February, and I would joke I hadn't seen a clean nose like this in that time of year ever since I started practicing, and everybody had no need for tissue. This year, whole different thing. We've got kids coming in with COVID-related illnesses but look just like it, so they all have to be tested, swabbed, quarantined, isolated. We then have to see our well visits because we have to get them in. We still have to figure out some way of doing all of that without making sure that my staff is not overworked, ill. So I guess that's what I really want people to know, is that what we saw last year was very different, and I think that it had everything to do with masking. And so I think that we're kind of entering into a very different time of year right now, with RSV, with flu, with COVID, with rhinovirus, with parainfluenza. I mean, I can go on and on and on, but the thing is they all look pretty similar. And so to figure out what we need to do is going to just do more than we as healthcare workers are going to be able to sustain.
Thank you. Do you have any idea or estimate as to what the percentage of patients that you're seeing have COVID?
So I think that that's a very difficult question. I mean, I could run a report, but you have to understand that we are testing not an entire population. So I would really rely upon the epidemiologists to tell us what our rates are versus what an individual pediatric office is going to tell you. I've had some of my other friends in the community say that they've had 20 to 30% in their office. I've had people say that we're upwards of 10 or 15, but this is a moving target. And we swab kids who come in to see us because usually they are either exposed or they are symptomatic. And so I think if we're going to talk about good statistics, then we probably need to be careful to make sure that we're talking about good statistics, and just anecdotal things that you're hearing from community pediatricians is probably not the best way to go. But the number of office visits, I'd say, are probably up a good 20 to 30% from last year.
Okay, thank you. I think we're ready to probably open it up to questions from members of the board. And then I guess when you ask your question, just preface if it's for Ms. Hilscher, if it's for Dr. Mellick. And I will start with Jessica, and we'll just work our way around the dais if that works for everybody.
Thank you, Ms. Owsley. My question is about the updated CDC isolation and quarantine guidance. Is that what we'll be following for Shawnee Mission? My greatest concern is that we've had a lot of staff out the last couple of weeks getting exposed to lots of things, and there's not anything we can do at this point about exposures that happened over the last couple of weeks. So I'm concerned we're going to have real staffing shortages in the very near future and worried about that disruption.
So in speaking with the health department today, and not Elizabeth, I'm going to answer that in that I hope to have the written guidance within 48 hours, which would mean I would put it on Monday's board meeting. But yes, it would be our recommendation to follow the 5 days.
Okay, thank you. That's good news to me for our staffing concerns.
Ms. Goodburn? Oh, you're okay.
I have a question too, but it's more district related. Should I ask that now? Okay.
Go ahead.
So I have a question about how we come up with our numbers, because according to our mitigation measures, we have a 3% threshold in a building before we automatically go back into masking within each building. So run me through how we come about that. How are these just sheer numbers of absences, or do they have to be COVID positive? Would they be presumed positive? Because I know it's harder and harder to get, or it's kind of hard to get a test right now, whether it be an at-home one. It's hard to get tested potentially. So I just wanted to know how we come up with those numbers.
So the 3%, and I'm going to ask Christy to follow up behind me, but the 3% would be 3% of positive COVID or quarantine, and positive COVID would include presumed positive if kids were at school symptomatic. So we would be including those kids as well in that 3%. It does not include the kid that goes to the orthodontist or the kid that might be out for something else, right? So it would be specific to COVID when we have that data. We would be running that data on Mondays, as we have all along. However, we're going to be monitoring consistently. So let's say we have an elementary school that's at 2.8%, and then we automatically Wednesday morning know that we sent a family of 5 home. And so we could make decisions during the week if we have them. The delay in testing, as you mentioned, and the availability for testing outside of, we still feel pretty confident about a 24-hour turnaround with our testing, but if they're being tested outside of the school district, that delay in testing could also impact that 3%. But we would do our best to keep it at 3%, but generally speaking, it would be a Monday update unless there was something significant in that building.
And those numbers, sorry, they include staff and students, right?
That is correct.
So a building's whole population is staff and, okay.
Certified, classified, and students. Christy, anything you would add?
No, and I would just reiterate that that is no different than what we have been watching building by building. So at the point that we find maybe a hot pocket that is brewing, that we wouldn't wait until Monday to take action and communicate.
And how would that be communicated then out to parents? Or, I mean, all of a sudden it would just flip the switch and the email goes out and it's like masks, or would we have masks available for kids? I'm sure we always do. Will we have those available for kids that potentially didn't get the word, or?
Correct. We have masks available. We're in good supply of our masks right now, and we would work with our building leaders so that that communication would come directly to the school community from the building.
Also, in my call with the county health department today, is they are working to get an additional supply of KN95 masks, and ask how many we would need. So we have a lot of masks on hand, both for pediatric as well as our high schools, and in our middle schools and high schools, they are KN95 that we're handing out when kids don't have them. Or adults.
So I have a couple of questions that kind of line up with Sarah's questions. So with watching the data with regards to 3%, we don't have the data today to know where our rates could potentially be with the buildings because the kids haven't been in school. So we don't have sick data for people right now. And so my question with the Omicron, with it spreading faster or its transmissibility rate, are we going to have a window in which we know that we're at 3%, or is it going to be like we have it in the building and then it spreads so quickly there's not an opportunity to rein it in? By the time we're at 3%, we're probably much higher than 3% because with that transmissibility speed, it changes the game with regards to your reaction time. So by the time you're reacting, you may be moving at too late a pace to slow that spread. So I'd like to confirm that, or to get some additional input on that, either from Ms. Solscher, and then maybe we can follow up with Dr. Melick.
Absolutely. I think that that's a reasonable concern, given how quickly this spreads, and it does have a slightly shorter incubation period than Delta did. So what you're looking at is probably 3 to 4 days before people are getting sick in your buildings. And so it is reasonable that given how quickly it spreads and the difficulty in identifying contacts when you already have that many positive individuals in your building, that it could get out of hand very quickly and you may skyrocket above that 3%.
Okay, and then the next question then is with regards to masking. So we had success last semester with cloth masks, and the transmissibility with this, there are recommendations coming out that perhaps cloth masks are not as effective. And so what I would like to know is, are we able to continue to have success with masking as we move into the semester, if that's a decision we were to make or to do? And can we talk about, maybe just for the edification of parents, so that they know, because we have parents reaching out who are concerned, how can you keep your kids safe? If a parent wants to upgrade a mask, or if a parent wants to do best mask practices, what does that look like? And can that child, if you have a child who is boosted and wearing a good mask, is that protection for that individual child?
All right, well, I will do my best to answer this question. So you are correct, is that with the increasing transmissibility of Omicron, there is some concern that cloth masks are not sufficient. Every time I've been here in front of you all up until today, I've been in a cloth mask. Today I'm in a KN95 because there is a higher risk associated with Omicron. And so upgrading your mask either to a KN95, a KF94 for those who are littler and maybe can't fit into a KN95, or double masking with a surgical mask and then a cloth mask are going to be better ways.
Okay, so we will just adjourn indefinitely at this point, and we will reconvene in live stream when we are able to do so.
Hey, Heather, you.
All right, welcome back, everyone. We are reconvening. So my question was with regards to efficacy of masks and the various types of masks that are out there, and whether or not we can successfully contain the new variant with masking. And I will ask you to just start over on your answer, if you could, and thank you.
Absolutely. So with the previous variants in the wild type virus of COVID-19, we showed that cloth masks work very well. We were able to slow the spread in schools. We know that individuals were becoming infected less often if they were at close contact when both parties were wearing a mask. With the increased transmissibility of Omicron, it is likely that we do need a higher level of mask than what we've been using previously. So that means either a KN95, a KF94 for the younger kiddos, or double masking with a surgical mask and a cloth mask is the best method. And you can see that here. I've noticed a number of individuals are wearing higher levels of masks. I am as well, as are people in my office. As for whether or not it will contain the spread, I think it's a tool in our toolbox, right? I've talked repeatedly, pretty much every time I've been here, about the fact that when we are talking about preventing COVID-19 transmission, it's a layered approach. We need a lot of different tools, and there's not a single tool that is 100% effective. Vaccines and boosters are one of our greatest tools, but we do know that there's still a lower uptake, particularly among some of our younger kids, the 5 to 11s, as well as we've not gotten sort of that really high level of vaccine coverage that we would really need, particularly given the transmissibility of Omicron. So layering masking, and particularly a higher grade mask, with vaccines, with keeping kids home when they're sick, with ventilation, with all of these different pieces, they're all really important to our ability to mitigate the spread. Nothing is perfect, but it is a very important piece to the overall strategy to reduce COVID-19 transmission, both in schools as well as in the community.
Thank you. So, Dr. Melick, would you echo those sentiments that if people...
Absolutely. Okay. I mean, I think that there is no one perfect way to completely stop COVID at this point in time, short of having people live like John Travolta did in Boy in the Bubble. And yes, now I am dating myself at how old I am, so everybody can know what kind of movies I watched growing up. But the best way to decrease transmissibility is to not be in the same room with someone who is infectious. And that's not going to be able to be perfect because of the fact that we're infectious often a couple of days before we start to show symptoms, not even to speak of the fact that there are asymptomatic people who are infectious and spreading. So then the next best thing is going to be these layered effects of vaccination is going to be number one. And unfortunately, because of the fact that Omicron seems to be so much more infectious, and the 2 doses of the Moderna and for children, the Pfizer, are only about 35% effective until boosted. And I think I'd read somewhere that the boosted dose is about 75% against Omicron. Then we're going to need to rely on good infection control, and some of that is going to be masking. While I agree with the fact that probably a surgical mask underneath a cloth mask is more effective, it is only going to be effective if it's consistently worn, and I think it is so much less comfortable to be layered masks like that than it is to have a good, higher quality medical type mask. And those are available for purchase by the general population. I have also stopped wearing any cloth masks outside of my home and have opted to instead wear a higher grade KN95 or even when it was really bad and I had to be in a very populated area, I think I had to go to my dentist's office. I actually wore my N95 there because there was several people waiting in the waiting room.
Thank you. I have lots of additional questions, but I'm going to make sure that we cycle through everybody. So I'm going to go over to Dr. Sinclair.
I'm not, I'm not sure who my question should best be directed to. I was thinking in part about the spirit of the COVID mitigation plan is, providing safety, keeping our schools open. And since we've been on winter break, we really don't know what the prevalence is of COVID cases within our school buildings. So by starting off with some degree of masking requirement, given the prevalence in our community for a short defined period of time while we assess what the positivity rate is there a sense, particularly during this kind of peak in the next 2 weeks, how long would it take really to get a handle on what the incidence rates is in our building? Is that something that would become generally pretty defined in the first couple of days, or,
That's a difficult question for me to answer right now. I would say that we'll know more, as we stand right now. Today's our first day back for the return for the semester with staff. It's a teacher work day, so we don't have a good indication at this point, I don't think, to speak to staffing. We started taking a pretty high volume of emails and calls yesterday from staff. Today, our COVID team shared that the majority of those phone calls have been from parents' families that are calling in where there's been exposures and wanting some direction on what to do for children in the home. I would think that by the time we get to Monday would be our first data dashboard update, where we'd have, Wednesday, Thursday, Friday worth of data would be the first time that we really would have a solid understanding. I mean, we'll likely be hearing from the nurses and from our COVID team Wednesday, Thursday. We'll hear more tomorrow. Our nurses are all in professional development, so it's going to be difficult to get to emails and phone. So it's just kind of a tricky time for us coming back from break to really give a good response.
Christy, can you clarify, is that just for, obviously we haven't been testing, but other places still have. So does the county give us the data for the last 2 weeks of kids and staff in our school, correct? So we do have some data. Is that accurate?
I'll start this.
It would be the county data.
The ability for the health department to provide that information to the school districts is reliant on us being able to interview families, because when we get test results in for individuals, all we see are their name, date of birth, and address, and their test results. So we don't know, for instance, if somebody lives in this district boundaries, whether they go to Shawnee Mission or perhaps go to a private school. So for us, especially given the large number, we have been providing that information, but even for us, given the current state of COVID in our community, we also don't have a good handle on it either. And generally, the communication is more reliable coming from parents to the school district and to us.
So can I rephrase? Thank you. Can I reframe the question? I'm just thinking, so in 2 weeks, would we have a pretty good handle on where we are by building in terms of positivity rate? So we would know, like within 2 weeks, whether or not we need to keep masks on in certain buildings or not.
I think we'll have a good indication by the end of next week.
Okay.
But yeah, 2 weeks would definitely give us a good amount of time to track the data and see where we're at with our dashboard updates.
Okay. Thank you.
Mr. Stratton.
I'll build on that question, coming at it from a different angle, and that is the experience of our peer districts also in Johnson County. Other districts around us have had different mitigation plans, some of which masking was optional middle and high school starting in November. So I turn to Ms. Holshoe as well as Dr. Hubbard. Do we know from our peer districts how their experience has been, and really specifically around test to stay? And then the other would be the 3% safety net. How many times do we know that they've had to trigger that after the change to going optional from 7th to 12th grade.
So to my knowledge, Spring Hill is the only middle school. Everybody else is high school only, so I want to clarify with that. And also to my knowledge, the percentage is a little bit different in each high school, so it's not necessarily, or in each district, so some are 3, some are 4, some play in other attendance factors, so it's not 100% apples to oranges in regards to that. But again, to my knowledge, Olathe is the only school that hit their percentages in 2 of their high schools before break. None in Blue Valley, 2 in Olathe, none in DeSoto. Is Elizabeth shaking her head?
Yeah, that's also my understanding as well. I would caution, however, that that was pre-Omicron and pre-given the sheer transmission that we're seeing in our community right now.
Reverend Guy?
My question is, I think what we're hearing from a lot of people is that so much of the rest of the world has moved on beyond masks, and is there really any benefit to the schools continuing to require masks when the kids and families are going out and doing all these other things without masks? So can you speak to that? What is the benefit to our students, our staff, our families, and also to the community at large if the school district continues to have masking?
Absolutely. I think that's an excellent question because you're right. In the community, generally, depending on where you're going out, people may or may not be in masks. I think what we've learned so far in the COVID pandemic through all the iterations is that the school districts, I'm sorry, my KN95 is really wreaking havoc on my glasses. The school districts do not drive community transmission, right? They are not the ones who are pushing that transmission number up in our community. It is the other way around. Schools are reflective of what's happening in our community. So when you have really high rates of transmission in our community, you then subsequently see it in our school districts. The way that I view this, though, is that, it's one thing for me to go into a grocery store without a mask on where there's, some of that incidental transmission, maybe especially with Omicron, it's more likely to happen than previous. What concerns me about schools is just the sheer number of individuals sitting in an enclosed room. I know that you guys have spent a lot of work on ventilation and making sure that's really high, which is an excellent tool, again, in this layered approach to mitigation. But you have a large number of students in an enclosed classroom for an extended period of time, and then they're switching and going to another classroom, and then lunches as well. And so when we've really been thinking through the new guidance from CDC as well as what this looks like, lunchtime, particularly in schools where there's no policy for, eating, then putting your mask on and then talking, those are really high points where we've seen transmission. And so I believe public health believes that masks are an integral part to slowing the spread. And I think that in particular, given what's happened previously with staff shortages, if you can slow the spread in schools and keep kids in class, which I think we can all agree is the best place for them to be, the best thing to do is to have as many mitigation measures in place to have that be as much of a possibility. And given what we're seeing with Omicron, masks, we truly believe are an important piece of that.
Ms. Borgman?
Yes, hi, thank you. Thank you, Ms. Malik, for Dr. Malik, and thank you, Ms. Holshoe, again, for joining us. We appreciate your time, and thank you for letting us, ask questions like this and have this discussion. So I was really proud of the board, and I am really proud of the board. On November 15th, the board voted 5-2 to really, we had a really low threshold for our tolerance for COVID. So we said, at 3%, if students had COVID or were quarantined, we would go to requiring masking at the individual building. So we were going to take an individual approach to this and look at each individual building, and our threshold at 3% is incredibly low. So, for example, if I look at Shawnee Mission Northwest, which has roughly 1,600 students, so only 48 students would have to have had COVID or quarantined for Northwest to go into mandatory masking. I mean, again, that is an incredibly low threshold. And I'm really proud of the work that we did. And we said, hey, listen, we're going to make sure we're going to do everything we can to keep our students and staff safe. So with that said, Dr. Malik made a comment. She said, pediatricians are very tired. Dr. Malik, I feel you, and I thank you. We're all very tired. School boards are very tired. We're tired of, this can continuing to get kicked down the road to us. Parents are very tired. Everybody's very tired. And that, I think, is kind of the problem. This has just been kind of a moving target with masks. We're saying, we need you to get the vaccine. Then we said, things will get better if you get the booster. Now, Ms. Holshoe is saying, we need to wait 4 to 6 weeks until the peak is over. I mean, we're all very tired. Dr. Malik also mentioned kids are less medically affected by this Omicron variant. I can say that in my own house. I had a child who had the Omicron variant, and it was like she had a cold. So I absolutely understand that. With a mask-optional approach, if kids are less medically affected, and we know that KN95 masks are going to really filter out 95% of a virus, what's so wrong with a mask-optional approach with a 3% threshold?
This is Dr. Malik. If that was directed at me, I think the actual question there, I kind of cut out. Could you ask again?
My question is, with a 3% threshold, which the board voted on November 5th, the member mask, K95 mask, and kids, I'm not trying to put words in your mouth, but I believe that you said kids are less medically affected. Can you help me understand what is wrong with our current plan that we voted on November 15th, a mask optional approach if it's below 3% per building level?
Well, so I guess I'd like to comment a little bit on, before I answer that question, I guess I'd like to comment a little bit on that we are all tired. I agree with you. We're all tired. And I think that actually adds into the idea of mask optional will mean that anybody actually masks. So I would argue that the problem with mask optional right now is the fact that we are dealing with a new variant. And I completely hear you at how frustrating it has been with the ever-changing recommendations of what we have seen. It's been frustrating for us in the medical community. It's been frustrating for people just in the general population. It's been frustrating for business owners. It adds to the fatigue that we all have. But what I think that people are not quite understanding is that you all are getting a direct look into what science is exactly like. This is what science looks like. This is what new discoveries look like. Scientists, doctors, epidemiologists, we're not soothsayers. We can't tell the future. And so we make a hypothesis, we test the hypothesis, and then we adjust the hypothesis. And you guys are getting a 24-hour less than news cycle of seeing science at work. And so what we knew, or what we thought we knew 2 years ago, is completely different because we're dealing with a mutated different virus at this point in time. We used to think that ulcers were caused by stress. Well, they're caused by bacteria. So it's ever changing. And I think that the concern is that children are not great at doing things that are optional if it's difficult. And I'm a parent of 4. So, if I told my girls, you don't really have to eat your vegetables. You don't really have to go to school if you don't want to. I don't know that at 9, if there was something more fun to do, they would have gone to school, even though it's what's best for them. So I think it's up to us as adults to figure out what the recommendations are for our kids. And I guess you could argue that it should be up to the parent as to who does that. And I'm all for parents' rights, and I'm all for people making good informed decisions. But I think good informed decisions is a little bit of a difficult thing at this point in time, given the fact that we can all sort of self-select for whatever we want to validate our position at this point. So I can go on the internet, and as I said, I could tell somebody that I'm the best pediatrician in the entire universe. And if I put it on the internet enough places and hire somebody else to put it out there on the internet enough places, well, I could search for that and find it. It doesn't make it true. By the way, I'm not, and please don't send patients to me. I have enough. But the thing that I'm concerned about is what's the harm in 2 weeks of seeing where we are, especially if we could use good, improved masking as a part of a mitigation strategy. We didn't see the vaccine uptake the way we wanted to, not like some of the other countries. And I would also argue that we are not the only country still talking about masking. Maybe we're one of the few countries that is talking about it in this amount. But if you look, there's plenty of countries that are still recommending and requiring, in certain instances, masking.
Yes, Dr. Malik, thank you so much. I appreciate it. And once again, I just want to thank you again for your service to our community and to kids, and thank you for caring about kids. I guess, did I hear you correctly? And again, I do not want to put words in your mouth, so please correct me if I'm wrong. Did you say that kids are less medically affected by this Omicron variant?
Meaning, are they less hospitalized in lower rates? I mean, you could probably talk to the epidemiologist who could give you statistics. I'm not a statistics kind of girl, but the answer to that is yes, they don't seem to get as sick. They are not occupying the hospital as much, but you have to understand, we don't have as many children's hospitals here in this area, and we're very lucky that we have a children's hospital, but they are already feeling the effect of COVID coupled with RSV coupled with flu right now. I don't know their exact numbers. I just know that the last time I talked to the infectious disease director over there, they were talking about it almost 50-50 COVID, RSV.
Dr. Malik?
And what you're used to is only RSV this time of year, and you've now doubled your number of patients, but you haven't doubled your hospital staff. It is affecting things other than just the children's health. And so I completely know what you're saying. But let me just give you an analogy. I'm an analogy kind of girl. I was born in 1973. I had chickenpox growing up, right? And when the chickenpox vaccination came out, I had a lot of questions about it. I am not a let's just do everything just because that's what people say. I want to know what the science is. So when I was a child and children got chickenpox, there were still children who died from chickenpox or complications thereof. And it was a very low percentage. Again, your epidemiologist could probably tell you some, but let's just say, for argument's sake, it was about 10 out of 150,000 that died from or got severe illness from chickenpox. So if that's the case, and you have mitigation strategies, which we do now, right? A vaccine that's very, very effective against chickenpox, and we can discuss whether the COVID vaccine is very, very effective, but at least it's another thing we can do. If you were one of those 10 children who died of chickenpox, would you care what the statistic is if there was something that you could have done? So if there's something that we could do that's going to help prevent that, whatever it is, and there are kids who are dying of COVID and are hospitalized from COVID, and I'll tell you maybe even more commonly, they're seeing things from long COVID. I've had athletes, college athletes in my office who can no longer perform their sport, who can't focus, who can't participate in their life. And so we talk about, long-term effects, and I think that's where I'm the most concerned, is what are these kids going to be dealing with when they're 35 and 40 because they got COVID? And is there something that we could have done? And so I'm not saying that we necessarily have to go back to let's not shut down the schools. That's never been my goal, ever. Not even when this was, let's, close the world down. It was like kids belong in school. But we are all going to have to do our part, I think, to make sure that that continues, because kids aren't the only people in school. We still need our staff. We need our teachers, who I know are very tired, and I never could do their job.
Thank you. Thank you, Dr. Malik.
Thank you, Dr. Malik.
I've got, hold on just a second, Jamie.
I just wanted to add one more thing. Yes, I do appreciate your thoughtfulness. Thank you very much. I do have additional questions, and I will respectively wait my turn again. Thank you very much.
Thank you. Ms. Holschuh, I think you may have additional information to add to that.
I do think, thank you. I had reached out to Children's Mercy today to find out what their numbers were, particularly after your question about the percent positivity that you asked Dr. Malik. And I was informed that over this past week, Children's Mercy has had a 25.1% positivity, and that includes everyone, inpatient, outpatient. They currently have 25 inpatients. 7 of those are in the ICU. They've never had a number this high, and they've been sustaining over 20 inpatients for almost a week now with COVID-19. And she reported that they don't test everyone in the hospital. So I think that, just sort of echoing what Dr. Malik said, is you're absolutely right, Ms. Borgman, in that kids do not have as serious effects as, say, elderly individuals. When we look at who's at the greatest risk for severe outcomes, it is not our kids. However, they do still have serious outcomes, and I think also echoing the concerns about long COVID, as a parent, as a scientist, as an epidemiologist, that's what concerns me the most about this disease, is that we know that it can infiltrate the brain and other body systems, and we don't know what the long-term effects are for that. Now, again, I understand that every parent has the choice as to whether or not they want to vaccinate their child, or, is okay with their child contracting COVID-19. But I'd also like to point out that we live in a society, and there are societal contracts that we abide by. We have staff, I'm sure, who are immunocompromised or, are not able to respond as well to the vaccine. They live in households. We live in a community with people where we know that, unfortunately, with Omicron, combined with some decreased efficacy of the vaccine, that we have lost individuals who are severely immunocompromised, even though they were vaccinated. And now I understand that the school districts have borne the brunt of some of this weight of the community in ways that the community has not reciprocated for the school districts. However, I think given what we're seeing at this point, where Omicron is as high as it is, as Children's Mercy is as tapped out in terms of the number of beds that are in use, the difficulties with staff, this doesn't just become about COVID anymore, and the same for our adult hospitals. It's not just that our hospitals and our Children's Mercy can't care for people with COVID, but what happens when there's a car accident, when there's a stroke, when there's a heart attack, if there isn't a bed to be treated because there's not staff, and the staff are already stretched thin with the burden of COVID on top of everything else that these hospitals are dealing with on a day-to-day basis. It's really a scary situation, and I think that is very hidden from the public because it happens behind hospital closed doors. But again, with the fact that there will be a statewide hospital chief medical officer call this week that has never happened, all of our hospital leaders, including Children's Mercy, are raising the alarms that things are dangerous in our hospital systems. And while I agree, everybody is tired of masking, I certainly am as well. Until we can get through this Omicron wave, we will see increased hospitalizations over time from this wave, on top of already high levels of hospitalizations due to Delta. Masks, in addition to making sure people are vaccinated and boosted and all these other pieces, it's a key piece to reducing transmission and reducing people from getting very sick.
I just want to add that I think that that's an important thing that maybe people don't understand, is that it's not just about COVID. It's also about the child that I could not get in to see the ophthalmologist because of what looked like a lazy eye, though I was pretty sure it wasn't a lazy eye, and it turned out to be neuroblastoma. I had to literally call and beg to get that child in because they are so short-staffed, and that's what this is affecting. It's not neuroblastoma, it's a tumor, it's cancer, in case anyone didn't know, but so this is what we're dealing with, that we don't have enough people to see anyone. And the nursing staff is just absolutely depleted.
So I'd like to ask a follow-up of Ms. Holschuh. What is the rate of hospitalizations at this time? do we know where our capacity is at for like our local hospitals for Advent Health and for Children's Mercy? Like, where are they at capacity? Are they close to capacity? What are we looking at?
They are very close to capacity. We have our hospital call this Wednesday, so we haven't gotten an update over the holiday weeks from them on a sort of one-on-one basis. However, I know that even 2 weeks ago, before Christmas, our local hospitals had anywhere from 15 to 30 patients waiting in the emergency rooms just for beds. I've heard anecdotally that people have been locally, that people waited 24 hours to get in a bed and then were subsequently discharged because they needed the bed for somebody else. Data are a little lagging with the holiday weekend, so Mark's dashboard isn't as up to date. But when we look at the total number of hospitalized patients, as well as the total number of individuals in the ICU due to COVID, we are at our peak where we have been both last winter as well as earlier this year. And that's on top of an even greater nursing shortage than we've had in either of those two occasions. And we're just now hitting a peak, or we're just getting hit with Omicron. So the anticipation is those numbers are only going to go up from here. So what is already a dire situation, maxed out at the places we've been in the last 2 years, is only going to get worse.
Okay, thank you. Ms.
So
Henry?
I'm on staff at Advent Health, and I get some of their information. And the last information I got from them was on the 30th. And they currently have plenty of PPE and beds. What they don't have is healthcare staff. That's going to limit. I mean, we can't have nurses taking care of 8 to 10 patients. That's not each. That's just not safe. So,
Thank you, Dr. Malik. Ms. Hembry?
Thank you. I have been really, I guess a little part of me feels like we are like trying to stem the tide of the Titanic or something here. Like, this feels like so much bigger of a problem than Shawnee Mission School District can fix with any variety of mask that we do or don't put on kids. I'm willing to consider all of the things we can consider, but I feel really overwhelmed by where COVID is for our community right now, as I'm sure you do, Elizabeth. What I hear in a lot of the emails I've gotten is just people who are incredibly fearful about Omicron in particular. My perception, you can tell me if this is right or if this is wrong, is that for people who have gotten their vaccine and gotten boosted and are taking the extra step of wearing a higher quality mask, they can feel relatively safe living their life. Early on in this pandemic, the word around masks was something like, my mask protects you, your mask protects me. It's my understanding that N95 masks are amazing because they protect the person wearing them regardless of what other folks in the room are or are not doing, which is why we could comfortably sit in this room with 40 people back there who were unmasked. Is that right, that once you get into some of these high quality mask situations, your individual masking choice does start to matter quite a bit more than what everyone else in the room is doing?
You are correct to some degree. When we talk about these higher grade masks and we think about what healthcare providers wear with the N95 masks where they're fit tested, I mean, that is the epitome of true protection at that point. KN95s are really good. However, I mean, I know I still have gaps on my mask. And so there is still some potential for transmission in both directions, even with some of these masks. But you are correct. If you are vaccinated and boosted, and you're wearing a mask, if you do have an underlying condition and are immunocompromised, that may change it for you. But if you're generally healthy and you have these added layers of protection, you can feel generally pretty comfortable even if you do get it, and there's a chance you may, it will likely be no more than a cold or something like that. But that is certainly for the population that's healthy.
Thank you.
Ms. Goodburn, do you have any follow-ups?
Well, kind of going off your questioning too, it does feel bigger in the community. So what do we know? Do you know anything about the Board of County Commissioners, and will you guys be testifying? I don't know, do they have a meeting this week? Will you be testifying and suggesting something to them that they extend the mask requirement maybe to the upper grade levels like they have in place for the younger children? Is that what you're going to be recommending to them, or do you know yet?
So the Board of County Commissioners are meeting this Thursday and are reviewing the current mask mandate. The Department of Health and Environment's role is to provide data and education and guidance on what we know from the science, and so that is what we will continue to do, and they will make the decision that they decide is best for the county.
So you don't particularly give them a recommendation then?
Our position is really more for providing the information and letting them come make that decision.
But this evening, would you have a recommendation for us?
Public health's stance is that masks are an important layer of mitigation in terms of preventing the transmission of COVID-19. And given what we see with Omicron, masks are incredibly important at this point.
Thank you. Do we know what the rate of vaccination is right now for our area, for our buildings? Do we have an idea where we're at?
I looked at the dashboard this morning, and for 5 to 11-year-olds, that's the only piece that I checked, just out of curiosity. For our zip codes, we range from 13% fully vaccinated to 39% fully vaccinated of 5 to 11-year-olds.
And do we have any idea the number of percentages of students that we have in 7th, 8th, 9th, and 10th grade? Can we break it down like that so that, I mean, because at least juniors and seniors have had the chance to get the booster, but for those other 4 grades?
I don't have updated data from the last time we provided that. We would need to take some time just to do another poll and see what additional reporting came in from families that was voluntary.
So that booster shot for the 12 to 15-year-olds, I think, becomes available tomorrow. Did the CDC provide their recommendation today? The FDA provided their recommendation today. So it's with the CDC. And did they get approval for that out this evening before our meeting, or did they not? They have not. So it's not going to be available tomorrow. We need to wait for the CDC to, okay.
Yeah.
So let's, for optimistic sake, let's say that becomes available on Wednesday, although we don't know for sure. I think, Dr. Melick, this might be a question for you. If that became available on Wednesday and every parent who wanted that to get that done, would there be a 2-week window in which they could do that? Like, do we have the capacity locally to get those kids vaccinated? And then my follow-up to that would be, at what point does that booster start providing protection to those kids? Like, do they have protection, some protection right away and then not full protection for 2 weeks? Or is it like you're not fully protected until 2 weeks out from that? So those are my 2 questions.
So I'm going to answer them backwards,
Okay.
Because that one's probably easier, because I don't exactly know, and I haven't read the data of exactly how long it's going to take for that booster. I know with the adults, once we were boosted, we were considered, less likely to be infected again after 2 weeks. So we go by what the science has told us, and so I haven't heard any of that. As for the first question, if, let's say, it gets approved tomorrow, do we have the capacity? I do have an office that provides the vaccine. We are one of a few in the Johnson County area pediatrician offices that provide the vaccine for children. So I'm going to have to go with probably not. It's not going to be a 2-day or 2-week turnaround in order to get all of these kids boosted. It's probably going to take a little bit longer than that. It's overwhelming. We've already had patients calling our office today, tying up my phone lines with, how can I get my kid their booster? The FDA approved it. Well, yes, the FDA did approve it, but now we have to go through the rest of the steps. We have to ask for more vaccine. Again, I'm still giving flu vaccines. I'm now swabbing pretty much every person, it seems like, who comes through the door of my office for COVID. That has increased our sick visits. We have phone messages out the wazoo. So, I mean, it's not like you just walk through my office. It'd be so cool if it was like a Mister at Disney where you just like walked under it and you were boosted and vaccinated. That'd be great. But it's not how it works. We have to have people who administer the vaccine, record the vaccine, request the vaccine. So between us, between the family practice doctors, between the health department, between the pharmacies, it's still going to take some uptick. Not to mention, I just have to speak a little bit about how difficult it has been lately to deal with pharmacies right now. I have family, I have office staff, I have patients who can't get their prescriptions filled for things like ear infections, high blood pressure, anything, because the pharmacies are also overwhelmed with the vaccination need right now.
Thank you. Dr. Sinclair?
I think most of my questions have been asked.
Okay.
I'll jump in. I'll go back through, but I think most of my questions have been asked and answered.
Okay, well, that may be the first time in board history. And that is said with love. Mr. Stratton?
Thank you. I have two questions. I'll try to merge them together. In my professional role on a daily basis, my role is risk management. And so we spend an incredible amount of time figuring out to what extent a risk is possible versus how that risk can be mitigated or managed. With that hat on, my question is about the risk of the individual versus the risk for the community. Our role here is to set policy on behalf of the Shawnee Mission School District. When I've watched this play out, I've struggled with, are we to make decisions based on the protection of each individual, or are we to make a bigger decision, and that is to to help protect the community or to manage risk in the community as a whole? So I share that story to say that's where I'm struggling with, which goes to my question. I'm hearing conversations about the mask. I'm going to offer my thought for a second. That is, the vaccine is very, very important to eventually getting rid of this problem that we're dealing with collectively. That being said, I really think that if we get the vaccine administered, that's a really big push. But that's not the conversation here at this table. This conversation is about the masking. When I read the emails, when I field the phone calls, when I talk to people in the community, what I'm hearing is this: I don't trust the other guy. I trust myself. I don't trust my fellow person in the community. Based on the conversation today, I'm seeing things a little differently, meaning what I'm hearing, and this is what I'm going to ask you to correct me if I'm wrong, with the vaccine, with the boost, with making wise choices as to where someone goes into public and wearing a high-quality mask like an N95 mask, the individual is protected as best they can. They've managed their risk as best they can. My question is, for teachers and for staff people who we're hearing from that are concerned about going into a classroom where a student may or may not be wearing a mask, do we feel like we've managed the risk to the point that they can feel protected, not 100%, but protected if they are vaccinated, boosted, and have an N95 mask?
So I completely agree with you, Mr. Stratton, and similarly to how I look at things in terms of a risk reduction and risk mitigation as an epidemiologist, and certainly from my perspective as public health, my view is the community as a whole. You know, I think for staff who are vaccinated, boosted, wearing a mask, even if their students are not wearing a mask, there is a chance that they may get sick. The likelihood that they get severely sick, as long as they are healthy, without sort of those underlying immunocompromising conditions, is probably pretty slim that they get severely sick. Now, I would still say that there is a chance that they do contract COVID, whether that's in the school building or out, especially given our current level of transmission, and they may end up having symptoms of a mild cold. Now, again, that's not a huge thing to worry about until it affects staff in all of your buildings, and the massive amount of individuals as an employer, that are impacted. And that's what we're seeing in the healthcare settings, in other work settings. We're hearing it from our county government, right, that so many of the employees are sick. And again, it may not be seriously sick, but if they're going home for the 5 days, moving to the shortened isolation period, it still does have an impact. So again, these are the decisions that I know you guys are having to weigh when you make these determinations.
Thank you, and I didn't know if our doctor on the phone wanted to add to that at all.
I guess I would also add in that when you think about your community, we need to think about our communities within communities. So while, we're talking about individuals living their lives and doing what we can do, I'm vaccinated, I'm boosted, I wear an N95 at work every day, and I absolutely know I am dealing with people who have COVID. And I do that willingly because I feel like I've protected myself as best I can. As I joke with my patients, none of you are getting kisses today. Nobody's getting hugs. It's just not going to happen because that's how I'm going to protect myself. But we also need to make sure that we can still be functioning to take care of the individual. And in a school, that's educating them. We need to make sure the schools don't close and it not be because of the adults who are the present teaching the children who are the future.
Thank you.
Reverend Guy?
I think most of my questions have been answered too. I guess I will ask clarification from Ms. Holshoe. Watching the KU Doctors Medical Morning Update, I believe they said that 1 in 400 Americans has died of COVID. Is that number correct?
I actually heard that statistic too, and I believe they were talking about KC Metro, and I have not done the math, truthfully, but I generally would trust them to determine that number. Again, those individuals are generally older, and we lost a lot of individuals particularly early on in the pandemic, but it has had a substantial impact. And I'd also point out that it's not just the loss of life, it's the long-term disability that has come for some along with COVID, particularly those who've ended up in the hospital or the ICU and on ventilators. That has significant health outcomes long-term, but then also those people who experience long COVID, some for years or a year, I guess, at this point. So it has had a dramatic impact, not only on our families for losing loved ones, but also people who are struggling to sort of live their lives as they did before COVID.
It's a staggering number to think about, and I guess that helps me when we become so focused, obviously, as we have to be on students and employees in our buildings, but then to take a step back and to say this is really what we still as a society are dealing with, and the numbers are staggering. So thank you.
David just did the math and confirmed that it is
okay.
Approximately 1 in 400.
Thank you.
Ms. Embry? Oh, I apologize. Ms. Borkman?
No problem. I'm going to just kind of echo a couple things and then just ask a question and point out another couple of things as well. Ms. Embry had mentioned this is bigger than SMSD. I completely agree with that. If you look at, SMSD has chosen to follow CASHA guidelines. And so, for example, a student could go sit at a basketball game on a Tuesday night next to their friend without a mask on in the bleachers and then show up in school the next day and have to put a mask on. I mean, they could sit at a movie without a mask on with their friends and, then go to school and have to put a mask on. I just feel like schools are, we're just being put in such a terrible position with school boards. The other point is that I want to thank the 200 plus physicians who wrote a letter to the Johnson County Board of County Commissioners, school board administrators, and school board members talking about their concern regarding COVID. The physicians had mentioned that in the letter it says, basically they are recommending masking K-12 students, teachers, staff, school administrators, and visitors to wear well-fitted masks until Johnson County positivity rate decreases to 5% or less. And I'm just going to go back to the vote that we took as a board on November 15th. And our threshold is lower than that. Our tolerance is lower than that. We said 3%. And that's for an individual building. And so again, I just want to point out, I mean, I pointed out the statistics for, Shawnee Mission Northwest previously. I'll point out, I just did the math quickly for Trail Ridge Middle School. So Trail Ridge Middle School roughly has 750 students. And at 3%, that would only be 22 students who have COVID or are quarantined. And so I think the vote that we took on November 15th is a really solid one. It says to our community, to our students, to our staff members, we are serious about this. We are doing everything. Our threshold is low. Our risk tolerance is low. And so, I just think what we did on November the 15th was the right thing to do. And I guess I just want to clarify, again, with Dr. Malik and Ms. Holshoe, perhaps if you want to add in, I mean, do you think that 3% threshold per individual building, again, if we're looking at specific numbers of 750 students at Trail Ridge Middle School, and only at 3% threshold, 22 students, 22 out of 750. I mean, that just is not a lot. I mean, our tolerance is incredibly low. And you had mentioned that if a staff member has a mask on and is vaccinated and is healthy, you can feel fairly safe. I just kind of want to get your thoughts on, do you think we did the right thing by taking that vote and keeping our students and staff safe with that really, with that 3% threshold?
I'm looking at Ms. Holshoe right now, and I'll let her speak to that. I know you don't have to grade us, but I think the heart of the issue.
That didn't come in my training.
Yeah, the heart of the issue is what we have sufficient.
I think that the 3%, having those guardrails, if you will, in place is incredibly smart. I think that it's a good measure to ensure that if you do see something, if you are seeing a spike in numbers, that you do have set metrics that say, okay, we're gonna mask up, we're gonna hold off, we're gonna let the numbers come back down. I think that is an incredibly intelligent way to approach this in a very sort of number science way. I do believe that given what we're seeing in the community for transmission today with Omicron, having students come back into the building completely unmasked and waiting to hit that 3% or waiting to figure out that you're at that 3% does carry with it some potential ramifications of why it has the potential to have greater transmission, just given what we're seeing and understanding that schools are reflective of what we see in our community. I would expect a fairly high percent of your kids to have COVID on that first day of school, whether or not they've been tested ahead of time and know it, or whether they're coming into school, say, pre-symptomatic, where they're already infectious, and maybe they don't have symptoms until Friday, and then you've had 2 days of kids walking around in your schools exposing other children. So I think that the 3% is really smart. I think that given Omicron, having a baseline and understanding where you are to start with is a way to potentially mitigate some additional spread.
Yes, Dr. Sinclair?
I'm not sure the protocol for this, but I would like to make a motion, assuming, I'm not sure if there's all questions have been asked.
I had additional questions.
Okay.
Let's finish the questions.
Okay.
All right. Ms. Hembry.
Sorry, my questions are primarily for Dr. Hubbard and the administrative team. I wanted to confirm just a couple of things. Three things. Sorry, we're all doing multiple pronged questions here, so I'm going to follow that lead. I wanted to confirm that we are making high quality masks available to any staff and students who would like them.
So we do have the KN95 available at the secondary level. I do not believe that we have the smaller, Elizabeth, help me.
KF94s.
I do not believe we have those at the elementary level. Is that correct, Dr. Ziegler?
My understanding is we have the surgical masks available in the pediatric size. Ms. Ousley has.
And we have a really large amount of those, so if a kid wanted to double mask with those, they sure could, but we, at the elementary level, but we do not have, that doesn't mean we can't get them. And then also, I know the county reached out today asking about providing some additional masks, and so we just need to provide them of a number we need. So I'll ask the question about, are the pediatric ones available as well, or do you know?
I am uncertain, but I can certainly inquire and get back to you.
Excuse me. Okay.
My other two questions. One is, I've spent just a little bit of time in buildings, and it seems like our staff are working incredibly hard to enforce the masking requirements that we do have in place. Could you talk a little bit about how consistently enforced and applied a mask requirement could be in our middle and high schools, particularly given what's happening in our community right now?
So I can't speak for every classroom every day because I'm not there, right? And none of us are, but we have made a concerted effort to be in buildings a lot more this year, and I think everyone would tell you they see us in buildings, and that's really important to us. So we are in buildings weekly. I can speak to what I'm seeing, and I would ask for some of the others to speak to what they're seeing, but I think at the high school level especially, you're seeing a lot of challenge to enforce. That's what I'm seeing. I almost feel like, I want to be really careful what I say here. I think it's difficult to enforce, and I think as a teacher, oftentimes I might spend a lot of times mitigating rather than teaching. So again, I can't speak to every single classroom, and all of those boil down to relationships too. I mean, a better relationship that I have with a kid, the better opportunity a kid's going to wear a mask in my classroom. So I can't speak to each one of those. I think it's a little better at the middle school, but again, not without challenges for sure. And to be honest, I'm seeing some of the same challenges with staff. I mean, I have walked into numerous classrooms in the last 2 weeks where a staff didn't have a mask on, and sometimes when they see me, they put it on, and sometimes they don't. And I'm sure it's true with principals too. And I want to acknowledge it's very difficult. It's difficult to wear a mask all day long. It's more difficult to wear a mask all day long and teach. I think especially at the lower elementary grades with phonetics and kids being able to see your mouth and form words. I hear teachers concerned about that. So I think it's difficult. And I've said this from the very beginning. Enforcing it when we're the only entity enforcing it makes it extremely difficult.
This is Dr. Nally. Can I ask a question about that and the enforcement? Because this isn't my area of expertise. I'm not a teacher. Is that okay?
If it's brief, yeah. I guess if it's a brief question.
And I would like
Sure.
for the others
I
to
guess
speak to
my
what they're
question
seeing.
is, how are you guys going to enforce the 5 days of masking once the kids are allowed to come back to school? I just think that would be as difficult, if not more difficult, than universal masking, trying to keep up with who was quarantined and who has 5 more days and who does not, and who is isolated and now is maybe asymptomatic so can come back to school. I guess that's my question about the enforcement of all of this.
I think all of that's very difficult, and I'm going to give the same answer the county is. We're going to do the best we absolutely can. But it will not be without flaw. And that's true even in our elementary schools right now where we're universally masking. I mean, I cannot guarantee that any kid walks into any building and 100% of the time, 100% of the people are masked correctly. Matter of fact, I can pretty much tell you that not 100% are masked, and especially not 100% masked correctly.
And my last question for our administrative team is if you have any recommended changes to the mitigation plan we adopted on November 15th.
At this time, we do not. I do anticipate a recommended change potentially on Monday if we receive guidance regarding quarantine.
Thank you.
Okay. Ms. Goodburn, do you have any further questions?
Can Ms. Holshoe speak to the 4 to 6 weeks? I mean, what they've seen in other countries and the data that's come about the variant and the steep drop-off you see 4 to 6 weeks?
Absolutely. So I will preface this by saying all we can do is see what other countries have experienced, and that doesn't necessarily always reflect what we will see. With Delta, we saw the UK over the summer have a really steep peak, and then it dropped really precipitously. We did not see that same transmission here, where ours sort of came down a little slower and plateaued much higher. But what we have seen is in South Africa, and again, their population looks dramatically different from ours. It's a much younger population. The comorbidities are very different than what we see here. But they have seen a rapid increase in cases of Omicron, and then it has dropped off. We haven't quite seen that drop off in other countries, but it seems to be getting there with the UK and other countries that were hit earlier than we were with Omicron. Part of the reason why this seems to be a reasonable expectation or something that is certainly plausible in our community is just the level of transmissibility. I heard Dr. Paul Offit, who is a vaccine expert out of the Children's Hospital of Philadelphia today on NPR speaking, and he said that he believes we're at about 80% immunity in our in the country as a whole, and that certainly varies, different locations to different locations. And with Omicron flying through, along with vaccines, we may start eking up into that over 90. And as each one of these variants continues to emerge, that's more transmissible, like Omicron, we need a higher level of that community immunity in order to be protected for us to get to that level. So, I think that there is a real potential that, especially with us being in winter where everybody's inside, and I think I'd warned about this in the fall, as everybody comes inside and, we're unmasking and we're in closed quarters, the virus has an ability to spread. And so we've seen a lot of that clearly over the holiday weekend and moving into the winter. So I would anticipate that we're going to have a really rough couple of weeks. But the current models or predictions, and those are just that, and they have every opportunity to change given people's behavior and whether they mask, whether they get vaccinated, but that we may start seeing this, mid to late January starting to come down, and by middle of February we may be back at some potentially still elevated levels. But again, at this point, that is just a prediction based on what we've seen, and anything is possible if I've learned anything in the last 2 years of this pandemic.
So in the letter that we received from 200 doctors today, there was some fairly dire language regarding potentials for, I think they said, the collapse of our healthcare system, and then just logistically, potentially the collapse of the education system based off of the fast rate of infection, and if people are sick and they can't be in the buildings to teach or to take care of people. Is that something that is accurate? Do you think that it is, that the threat is dire to the point that we are looking at collapse of systems?
I believe that we are at a tipping point currently. I don't know that I would use the phrase collapse. However, here in Kansas, in the Kansas City Metro, we have not had to use what they call crisis standards of care, and Dr. Milliken can speak more to this, I'm sure, where really difficult decisions about who gets to get care are put in place because the hospital systems just can't take on anymore. And I think that we're also, especially speaking of the healthcare system, we're also in a really dire situation because Omicron is hitting every community in this country, and it's going to continue. And so, there's been a really big struggle over the last 2 years, particularly in peaks of COVID transmission, where patients are being transferred to hospitals 10 hours away because there just aren't any beds locally. And when you fill up all of the hospitals in our country, or all the ones even remotely close, and you don't have anywhere to transfer patients, hard decisions have to be made. And the fact that we even discuss this concerns me. I think that, none of us want to get to that point where, doctors who sign an oath to do no harm are having to put into place standards that are developed for them for who gets care. I think that what we've seen in both healthcare settings as well as in other employment locations, we have seen employment shortages because of so many people getting sick from COVID, especially Omicron for those areas that were hit before us. We're a little late to the party in this country. So again, I probably wouldn't use collapse, but I do think that there is the real potential, given just the sheer number of individuals who are and will be infected with Omicron, that it will have dramatic impacts on different entities and systems in our community.
And then I have one more question. So we're talking about when we hit our 3% threshold, as the current policy is written, that masking goes back in place for those buildings. And at some point, there's a threshold where if there's enough infection in a building with any infectious disease, where the health department would step in and say, okay, you know, this building is going to have to be closed. I think at one point, my child's school closed because of a flu infection. Like, everybody in the building got the flu. The health department stepped in and said, you have to close it down and deep sanitize everything. Is there a threshold level of infection where the health department steps in and says, okay, we're going to, you know, there's so much COVID in this building, we're shutting this building down? And if there is, what is that threshold?
So I think that, you know, certainly, so I've been doing infectious disease epidemiology for, you know, over a decade, and there have been a couple of occasions, you know, even when I was at the state health department, where we did recommend, particularly around a norovirus outbreak, for instance, that they close down for just a couple of days to get that cleaning done. I think, though, that if one of the huge lessons learned, and I think we all knew it inherently before the pandemic hit, was that closing schools is not a great option ever, truthfully. You know, and I think that it is Johnson County Department of Health and Environment's, I'm trying to think of the right word, you know, belief that if we can keep schools open, if we can keep kids in school, that's what we do, as long as we can do it safely. So, you know, there is no threshold where we would step in and say, you've got to close. I know that there have been a couple of times where we've consulted with your staff, for instance, where there was just too many cases. They couldn't wrap their arms around the number of contacts and figure out who was what, and so it was a couple of days to catch up. You know, I think that additionally, you know, when we talk about COVID versus something like norovirus, which people tend to refer to as the stomach flu, which is incredibly infectious and lives on surfaces and takes a lot of deep cleaning, I think there's more benefit added when you need to close down for norovirus and actually clean the school building, where we know that that's how it's transmitted, versus COVID, which is not spread nearly at the rate from environmental surfaces as something like norovirus. So, you know, outside of there not being enough staffing, which becomes a school district decision, unless there is something really dire, I don't anticipate us coming in and recommending you close a building.
Thank you. Are there additional questions on this side of the dais? No? Oh, Mr. Stratton.
One quick last clarification, and that has to do with the age groups that we're talking about. The Johnson County Board of Commissioners has a current requirement that the 6 through 11, I think it is.
K through 6. It's grade level, K through 6.
Okay,
Grade.
K through 6 is required to continue to mask, and they're going to have a discussion coming up here Thursday about that. How about the other 6 districts within Johnson County? Where are they are they all different with middle versus high school? Because our plan currently just breaks it out as the K through 6 elementary, and then secondary, which is 7 through 12. So is that middle group need to be adjusted or addressed?
So, Mr. Stratton, the reason for that is we're the only school district that doesn't have 6th graders in our middle schools. So they're dealing with a different dynamic because they have 6th graders in their middle schools. And in some cases, 5th grade. Some of their middle schools are 5 through 8. And so that's why our plan sits like it does, because those 6th graders are sitting in our elementary schools, so we don't have that dynamic.
Thank you.
Okay.
Can I ask one final question?
Go ahead.
We spend so much time talking about masking. And I want to confirm, it is my perception, I know we've talked about sort of the Swiss cheese model, layered mitigation strategies. We've talked a lot about breakthrough cases. The vaccines we have are incredible. They are doing exactly what we wanted them to do. Even though we are seeing breakthrough cases, we are not seeing them lead to serious hospitalization and death, which is what a vaccine is supposed to do. So can you speak a little bit to the importance of vaccines? Because I don't want people to hear this conversation and think, what's the point of getting vaccinated?
I really appreciate the opportunity because you're absolutely right. You know, when COVID first hit and they were predicting we would have a vaccine in a year, I kind of scoffed at it. I never actually imagined that was going to be possible. And it was an incredible, you know, scientists coming together along with government to ensure that things were done properly, but allowing it to be at a speed at which we could have a really, really effective vaccine in a short time period against a novel disease. The COVID-19 vaccines, particularly the mRNAs, so the Moderna and the Pfizer, and Pfizer is the one that's available for children, have shown to be incredibly effective. And now, yes, with Omicron, we do see that drop to 35%. However, with that boost dose on top, that third dose, it brings it back up to 75%, and it is doing incredible at keeping people out of the hospital and having severe illness and dying from this disease. You know, when you talk or listen to any of the chief medical officers from the local areas talk about who's in their hospital, the vast majority of individuals who are hospitalized with COVID-19 are unvaccinated or under-vaccinated. And typically those that are vaccinated who are in the hospital, again, have either underlying medical conditions that make them immunocompromised or are elderly and also have additional medical conditions. As a parent, you know, I think that seeing this vaccine come out at a speed, I understand, has made people hesitant and thinking that it wasn't done properly, but it was. And I think that we've actually seen evidence to that lately. As much as for anybody with kids under the age of 5, it was a huge hit to hear that the Pfizer dose wasn't sufficient, but it shows that they're doing the science and doing the work to make sure that we have vaccines that are effective and safe for our kids. And so absolutely, I think that the best tool in our toolbox, I talk about this a lot, right? The layered mitigation, the best tool that we have to get us all out of this pandemic is this vaccine. And I would also counter anybody who, you know, makes comments about the fact that, well, now we need a third dose, and so it clearly wasn't. There's a number of vaccines that we get multiple doses of. Anybody who's gotten their kid through their, you know, well child visits under the age of 5, you know, some of those vaccines, I believe, are 4 doses. Or a flu vaccine, for instance, we get a new one each year because of the mutations in the flu vaccine, in the influenza virus. And so absolutely, the vaccines are truly, you know, in my opinion, one of the greatest feats of modern medicine and science, to have so many people come together to have such an effective vaccine after such a short period to a novel virus, that quite honestly, if we had better uptake, we probably wouldn't be in this position that we're in right now. So if you are hesitant, please go talk to your physician. Dr. Mellick, if you have children, you know, go talk to your pediatrician. It is very safe, very effective, and can help protect yourself or your children and those around you from developing serious illness.
I would agree with that. I think that the vaccine is very safe. Yes, it came out quickly. Again, I think the scientists should be very proud about that because there were not shortcuts done. It was just done quickly because it needed to be. And I think that I'd like to say one of the things that I hear most parents are so concerned about is what is this vaccine going to do to my child in 10, 15, 20 years? And my answer to that is nothing. It can't. This particular vaccine its long-term effects from the vaccine itself will be seen in 2 to 4 weeks because the vaccine is in and out of your body, and what is left is the immunity that you mount to it, just like immunity that you mount to common cold or influenza or the actual COVID disease itself. So it's not something that is going to have long-term effects. That's just not how the science would work. And so I think it's very safe, it's effective. I recommend it for my patients. I gave it to my children. I am waiting for that 12 to 15-year-old booster to be approved. And guess what? I have it in my office, and my kid might be the first one to get it. Probably not, actually, because she's too baby. But she'll be very quick once it's approved.
Thank you both. So I think we may be ready to have an opportunity for discussion and motions. And we did receive a request from a board member that our final vote on whatever we vote on tonight be done via paper ballot, and so when we get to that final portion, we'll pass the paper ballots down to Terry, and Jamie will email Terry her vote, and then Terry can read them all off at once. But before we get to that portion, there may be some back and forth with amendments or extra things, so we'll go through this a little bit at a time. And I think Dr. Sinclair had one earlier, just a minute ago. So I'll turn to Dr. Sinclair.
Do you want to start with the motion, or is there a discussion first? Or?
I think I was going to say start with the motion and then we can discuss, but I'm happy to do it vice versa. So we can start with discussion first if we want to go that route too. I'm fine with whatever. Motion's fine.
Okay.
Okay.
I do have a little bit of a preamble to my motion, so a couple of bullet points just so you know where I'm coming from. So keeping in mind kind of our collective goal to keep students learning in person in a safe environment for students and staff. Given the rapid spike in COVID-19 cases in the Johnson County area and globally, to levels that are unprecedented. I think Ms. Holshoe said we're at 637 per 100,000 today. Given we have a portion of unvaccinated staff coming back from winter break, when levels of active cases among our building population is unknown, so we'll need a little bit of time to know what the levels of active cases and quarantine are in our building. Given the fact that school attendance is mandatory and almost all district positions are required to be in person, given our desire to slow, if not, at least not accelerate the spread of Omicron among staff and students so that our buildings can stay open through the peak of this COVID wave so our hospitals don't get hit any harder than they are now. And given our second semester 3% building level threshold for masking, which I think is, from feedback today, is an effective plan. And then potentially a little bit more time for students between ages 11 and 15 potentially to get a booster. So given those, I move that Shawnee Mission School District delay implementation of the second semester 2022 COVID-19 mitigation plan for 2 weeks, with the exception of test to stay effective date, leaving that as is, and change the effective date of the optional, essentially changing the effective date of the optional mask wearing to, say, Monday, January 17th, or 2022.
I will second it. And we can open the floor for discussion. I will say that I concur with your preamble. I think it's disconcerting that we have a population of students who would want to be taking, their families would want to be taking those personal responsibility measures to heart and getting that boosters to give their kids that opportunity to be as protected as they can be. And they aren't able to do so yet. And part of the logic in the summer was, we want to get the kids who are mandated to be in our buildings because school attendance is compulsory, the opportunity to get access to those vaccines. So and I think in general, with regards to the fear of how fast this could go and how it could then impact our ability to continue to provide in-person learning, and if that has been our overarching goal for as long as it has been, I think the 3% number is great, but we don't know where we're at right now, and if this moves fast enough to where it jumps over that 3% and we end up much higher than that, then we're not able to use it. So, in light of these things, those are my concerns.
Heather, when you say it jumps much higher than 3%, we won't be able to use it, are you referring to the possibility that we get shut down by the health department at 10%, or what are you referencing?
No, I'm looking at it from the perspective of that it's a reactive mechanism to slow spread. And if this moves as fast as the measles, then once it's started to spread, it moves, everybody has an opportunity to get it. the measles is a disease that, I've heard pediatricians joke that you can catch it through a brick wall. And if that is where we're at with the level of contagion for this, that means that if there is somebody in the building that's positive with it and they are unmasked, then they will have exposed, almost everybody there. So it's like you don't have that opportunity to rein it in before it's already done.
My assumption would be is that it's possible that every building has a positivity rate higher than 3%. And so let's give us some time, and I don't know what that magical amount of time is. That's kind of one of my previous questions. So is 2 weeks sufficient time to get a handle on knowing what our positivity rate is? And then from there, we can go back to that more measured, strategy of going optional or not, because we know at that time. But my assumption is that the rate would be higher at this point in time.
So are you thinking that if it is that way, that somebody would want to come back to the board and change this again and extend it past January 17th?
I think we would have a plan in place that would work then. We would know. So we would know if we have, if some of our buildings are lower than 3%, then they could go optional, or that if the building is higher than 3%, then they would stay mask required. I'm thinking that we would have a period of time where we would have the data where we could put that back in place. But we've been out on break for 2 weeks and coming back at a time when the rate in the community is higher than it's ever been. So that's kind of where I was thinking, is that I think the policy is good. I just think that we don't know what the rate is because we haven't been in school, and it's very possible. It's very likely that it's higher. But let's just not take the risk. Let's keep the mask in place, get a handle on what our rates are, and then go to optional in those buildings where the rates are lower.
Can I ask, so I will say we voted in November on the plan to make masking optional beginning today in middle and high schools with this 3%, I'm calling it, safety net in place. What I really like about that idea is that it sets us up for success over the long run. I think Omicron is not the last variant that's going to come. This wave is not the last wave that's going to come. And when we start identifying data to drive the decisions about masking, that is a good place to be sustainable over the long haul. I also like that we have flexibility across buildings. So if you have a school that has a really high percent of students who are vaccinated, there will be some freedom that comes with that. I also like that it's not as volatile. I like that we don't have to have a 3-ring circus as a board every time we want to take a vote or make a change on masking. We've already set some metrics that we're looking at to decide what mitigation protocols we're using. There's a lot good about this 3% safety net clause. I think the thing we need to figure out is how we're going to use it, because this same argument about we don't know what the numbers look like, it's going to apply after spring break, it's going to apply after Thanksgiving break, it's going to apply after summer break. So I don't know what that means, but I think we should be building a plan that can last longer than 2 weeks. I don't want to come back every 2 weeks and have this vote again and again and again. So I don't know what that looks like, but I want us to get to a place where families can consistently count on our schools to be open, and they can understand what we're looking at to decide mitigation measures. Brad.
A couple of things. Number one, appreciate the motion, and I'm struggling with words. I want to make sure, because I appreciate what Ms. Embry said about this is going to be a living document that we're going to put in place, and then it's going to be having to be interpreted based on what the current situation is. So use the word delay, and maybe a friendly amendment might be to extend, because currently we have something in place, and so are we stopping it or delaying it, or are we extending the current plan? We aren't changing anything in your proposal. We're just extending it. A delay is a change to me, where an extending is just changing the date. But that's splitting hairs. Okay. The other piece, though, is just the mere logistics of us as a board being able to visit this. So when I look at our calendar, today's obviously the 3rd. We have 2 scheduled board meetings next week on the 10th, and then 2 weeks after that on the 7th, on the 24th. The date that you're proposing is in between those 2. So we conceivably could have another meeting and therefore be meeting every week. Meeting we meet next week on a regularly scheduled, and then the 17th comes and we're having the same discussion again. Do we extend further? The other piece is, for me, I'm struggling with two pieces of the timing of today. Number one, we know that the Board of County Commissioners is going to meet Thursday. They're going to weigh in on something that at some level supersedes what we can do. And then secondly, we have a new board member that will be seated a week from today. So I appreciate Reverend Guy coming back one more time to this table, but at the same time, I really would like to hear her voice on some of this decision-making going forward. So for those two reasons, knowing that the Board of Commissioners meets Thursday and that we have a new board member being seated on the next Monday, I'm struggling with really voting on anything that goes even beyond next Monday.
Reverend Guy?
I'll address the second concern. Yes, I was not supposed to be back here again. I said all my goodbyes last month. And so there were some concerns expressed to me that maybe this was a vote I might even recuse myself from because I'm a lame duck and April Boyd Nerona is going to be in this seat in a week. But I also did not feel comfortable essentially leaving the seat empty. I was elected to serve a 4-year term, and I'm still in that 4-year term, and so I felt like it was my obligation to come and still represent the Shawnee Mission West area and be a part of the board, even though I would have preferred to be home tonight. But I did want to talk to April because I did have a concern that I might vote on a policy tonight that she might not be comfortable with. And so I just wanted to talk to her and to hear from her what her thinking was. And of course, I didn't have a motion, so I couldn't tell her this is what I think we're going to be voting on. But I just told her where I'm coming from and what I was thinking and feeling, and then she shared with me what she's thinking and feeling, and it was in very close alignment. So after that conversation with her, I felt comfortable coming and having this conversation and taking a vote tonight. And but obviously she does have her own voice, and next Monday she will get to use that voice on this dais and take whatever vote she wants. But I think there is an urgency here, and there have been urgencies for the last 2 years, and another thing we're tired of. I think Omicron hit right when we were heading out on break, or at least started really ramping up, and to me, that's the reason we're here tonight. It's not because we just feel like we need to have another conversation about this. It's literally the timing of Omicron right when we were going on break, and now the students are coming back, and we're telling them masks are optional, and we don't even know what the percentages are going to be in our buildings on day one. And so that's why I felt like this meeting needed to happen, and this conversation needs to happen, however the vote ends up going. But so that's why I'm here, and that's why I'm going to vote tonight. And I think it makes sense to give ourselves 2 weeks to try to figure out what's going on in the buildings. And everybody hates masks, and everybody is so ready to get rid of them. But I think 2 weeks is not a whole lot to give ourselves and to give our students and give our employees to try to make this plan work. That 3% is great, but we can't. That's not going to be a great threshold unless we know what the number is. And I don't feel like we're going to know what the numbers are coming back from break while Omicron is spiking. So that's my comment.
I have a question logistically. I don't know what's going to happen. I don't think any of us knows what's going to happen at the Board of County Commissioners meeting. But should they do something that changes the mandate that they have in place, we then need to meet to vote on that issue subsequent to whatever it is that they do. So they may not change anything at this Thursday meeting, but they may change something at their subsequent Thursday meeting. And I don't know the date for that. I don't know that second
I
date.
believe it's the 20th, so I think both of them coincide. Brad, you might be able to confirm, but, so if they met on the 6th, we could address it on the 10th. If they met on the 20th, we could address it on the 24th.
Gotcha, okay,
Can I just add a comment?
yeah.
Can I
yeah.
add my perspective as well?
Yes,
Yeah.
go ahead, Ms. Morgan.
Thank you. First of all, Reverend Guy, thank you for coming back. You should have changed your phone number. So you were a trooper. Thank you. Regarding the specific motion that has been made, I guess, just to echo what's been said a little bit is, first it's 2 weeks, then it's 2 more, then it's 2 more. So I just have concerns about the 2 weeks. Again, and I just am really proud of the work that the board did on November 15th. The 3% threshold is lower than the 5% that the 200 physicians recommended, and we're looking at individual buildings. Again, just to reiterate what was said by our medical experts, kids are less medically affected by the Omicron variant, and if you are masked up, vaccinated, regardless of what the person next to you is doing, you should feel pretty okay. So I do appreciate the motion, Dr. Sinclair, thank you. But, I just think the concern of the 2 weeks won't act, or my concern is 2 weeks won't actually be 2 weeks.
Yeah, go ahead.
Okay, so I just, I hear collectively some of the concerns. I just want to state for the record that I really support our semester 2 mitigation plan. I think it's sound. I appreciate the ability to wrap it around individual buildings, and my 2 weeks or whatever that appropriate period of time is, I'm open to, if it needs to be different. But my proposal really is just about the fact that we are coming back to school and we do not know what our transmission rates are, and Omicron is the most contagious variant we have experienced to date, and so it's very likely that the prevalence is higher than 3%. So I just am suggesting, for the sake of keeping our buildings open and keeping our staff and students healthy and slowing the spread, that we give ourselves time to collect the data. If 2 weeks isn't the right time, I'm open to knowing what that right time is, but I would rather make this an evidence-based strategy. And to what Reverend Guy was saying, it's just the timing of it. So there is very good data to suggest that our buildings are not at 3%. That's all I'm saying. And I want to keep our buildings open, and we have staff that are not vaccinated. But I really do support the plan. I'm not going. I have no desire to come back and keep asking for 2 weeks.
Would a week be sufficient for us to have that data?
We'll run the next dashboard update on each Monday. So we'll have a partial week of data to report once we get back.
The problem is the next week, the week of the 17th, is a partial week. We don't
Again.
have kids on the 17th or the 18th.
If we voted to do a week tonight and then voted to do a week the subsequent night, depending on where we were at with the data, would we be addressing Mr. Stratton's concerns with regards to having April at the table? And then we could, if we don't have the data, we could see where we're at. And then I don't want to have to do the vote again. I think that it's hard as it is, and so I think the 2 week window is probably better out of the gate so that we don't have to continue to have the conversation again next Monday.
Just for clarification, on the actual motion, it indicates Monday the 17th, if I heard correctly. So does that mean, what does that mean for the 18th? Does that mean we're having a special meeting on the 17th? And it is Martin Luther King Day. And so I think I would need details, I guess, to move forward with that motion.
So
if that motion were to pass, I would need more details.
Okay. My intent of the motion was, I was really struggling for a period of time in which we would know what building rates were. So that's why I went with, 2 weeks has been the period of time that we've been using through COVID to change status. So I think part of it just came from, I don't know what the magical number is. So I just went, the date was effective today, so I, just was proposing that we change the effective date for 2 weeks, which would put us 2 weeks from today would be Monday, January 17th. That's where that date came from.
And then we revert or then implement the semester 2 strategy.
So the semester.
But we'd have the data to implement it. So we wouldn't be changing the semester 2 policy. We would just be delaying its implementation, and then it would automatically go into effect on the 17th. So that we would not.
That was my intent.
So that we would not.
Regardless of what the data says.
Well,
I mean,
then we would know whether some buildings are still in mask required, correct? Like we would say mask, we would be able to know whether certain buildings at that point are under 3% or over 3%, right? So it's mask optional except for those buildings over 3%. So by whatever, if we would know by Monday, January 17th, which buildings meet those thresholds.
And so Wednesday, based on how it's written, assuming it passes, on Wednesday, we would just be implementing that,
Yes,
regardless.
yes.
I think you for sure need to change it to the 18th because no staff will work on the 17th.
Okay.
It's just my suggestion. That's.
What, did you say something in the motion about the test to stay program?
Well, so I was thinking the effective date of the part of the second semester mitigation plan includes the test to stay, and I didn't know if we wanted to change that effective date or keep it today. I didn't know if I needed to decouple the test to stay program in the motion.
Are you planning to change anything other than masking? Like what about athletics and activities and Keisha? Really only
Keisha's voluntary now, this is separate. Right, Keisha's is separate.
It's in this plan.
It is not. It sets in a separate plan.
Okay.
Yeah, it sets in a.
So all of this or just the masking piece?
So Keisha's separate, so this would just be the COVID mitigation plan, second semester.
So there's the Keisha statement in there, but then we also have the activities guidelines that I guess that we do link.
Like visitors to
It does
schools,
sit in
there's a lot in here.
Yeah, there is. The other plan
So
that
I'm trying to follow along remotely. So is the motion 2 weeks, masking for 2 weeks, mandatory masking 2 weeks? I thought that was the motion. Please correct me if I'm wrong. I thought the motion was mandatory masking for 2 weeks until we have collected the data.
Yes, the motion really is changing the effective date of the second semester mitigation plan. So extending the date of the mitigation plan to
January 18th.
So what do we have in place between now and then? And if we extend that one or delay it, what's in place now?
We'd be extending last semester's mitigation plan.
the plan that was in place yesterday, technically, would still be in place.
So we'd go back to no visitors allowed in middle and high schools and elementary schools for the next 2 weeks?
That's correct.
Thank you for helping me think through.
I'm not going to ask my question until Sarah looks up and says, nope, I'm not going to ask a question, because it looks like you're formulating one.
Well, was there some, I don't know what that, I mean, that plan, did that plan have anything in it about test to stay? Last semesters? No, I don't think it did. Did it?
Okay,
No.
so I guess the question is,
Can we,
so there are components of the plan. I'm just trying to figure out
Are you suggesting that we extend the start date from January 3rd to January, let's say 18th, or whatever date you say, and begin test to stay on Wednesday. Is that what I hear you saying?
Yes, but Ms. Goodburn is suggesting that might not work. So we passed the 2021, we passed the second semester, 2022 COVID mitigation plan. So the two components that would be extended would be remaining in masks, and mask optional would go into effect with the 3% rule on January 18th. The other piece of that then we need to address is visitors. So if we extend allowing visitors to the January 18th date as well. So do we need a moment to look through the second semester plan?
Well, I would think that if we were going to do something like this, potentially, that you would just edit under secondary schools, mask wearing inside middle school and high school buildings is not optional until January. So, I mean, keep this document all in place, except for you would just maybe edit that line.
Right, to change the effective date to January 18th.
Yeah, is not optional January, whatever the date is, to the 18th, and then after the 18th, it will be optional, period.
Okay.
Can I?
Right?
Can I just?
Is that what you're looking at?
I guess what I'm saying is the very first paragraph just simply says the mitigation measures go into effect January 3rd, and all I'm hearing this motion is that that's changed from January 3rd to a date that's extended. And that otherwise, everything in this document takes place beginning that January date.
The date of the 18th, right, or whatever she said.
Yeah.
So that would mean, it would negate everything until the 18th. And I don't know what we revert to. That's what I'm I'm struggling with. Why wouldn't you just?
Do it the same day same way we did it on the last day of school in December.
Well,
Correct?
Oh, I don't
So
know.
the August 5th plan would remain in place. That might need to be part of the motion.
But the
Am I correct on the August 5th plan?
But the problem is that didn't include any of the test to stay, and I think we want to ramp that up as soon as we can, right? I mean, isn't that the whole thing? We want to keep kids in school and test to stay.
If we're going to have staffing challenges, we're going to need test to stay to weather them.
So do we want to?
So that's why I parceled out test to stay.
So do we want to? Okay, I understand what Sarah's saying. I get it.
Can we just edit this document?
So can we?
We wanted to do that.
I gotcha. I think the proposal then would be to amend Mary's motion to alter this document so that what we're altering is to just delay the mask optional portion to January 18th. And then everything else remains the same. It's just that masking is in place for 2 weeks. Is that where you're at? Should we do you want to make a motion to amend it to do that, or?
So you have a motion on the floor that you've got to address first.
Right, but can we not amend it before we vote on it? I think we can amend it and vote on the amendment and then do the motion itself. So we can amend it so that it is.
Okay, so, hang on.
While she's formulating that, I want to answer your question from before, Ms. Owsley, and that is that based on the dates that we're discussing here, all falling within the January timeframe, I no longer have the concern that I did about something that would potentially be proposed that would extend it out to March, April, May.
Okay.
The date in June, no matter what we pick, will not change how I choose.
Okay.
I just want to point out that someone had also brought up visitors in schools. I mean, that's another piece of it, so I just want us to be very clear on whatever the final motion is. What pieces are we talking about that are in place now versus what pieces would become in place on January 18th?
So if the motion is amended to just impact mask optional to mask mandatory for 2 weeks, then we would keep the other changes here, and we would only change that so there would still be visitors, but they would have to be masked. That's how I would read that.
So in that first paragraph, does it work to add the mitigation measures below go into effect January 3rd, 2022, with the exception of a delay in implementation of mask optional protocol and visitors until January 18th, 2022?
Okay, so I think that works. Does that,
Mary, when you say visitors, do you mean visitors would be required to mask, or we're not wanting to have visitors in our buildings until after the 18th?
I think we're saying that visitors can come, but they have to be masked. Because instead of reverting to last semester's policy, we're amending it to be that we're amending this policy.
Understand, thank you.
Okay.
It does state under learning opportunities, the last bullet point, visitors are welcome in schools in a limited capacity. See the winter guidance document here for details. All visitors must follow the building mitigation protocol.
So that works too then if the building then, yeah.
Okay.
Yes. Okay.
Does that work, Michelle, would that work then for visitors coming in schools if we extend masks in school to the 17th with a hard stop date on the 17th and make it 18th, make it optional after that? Does that cover us with the visitors though, making sure that they follow that?
The winter guidelines saying begin January 3rd, outside guests will be allowed past the main entrance. They will not be allowed in cafeterias, and approved field trips will be supported to the extent transportation is available. So I think that if you amended, I think the statement in the learning opportunities covers the fact that visitors can be in schools as long as they're masked. It does still allow for field trips to happen if we choose to do that.
I actually just realized, Dr. Millett is still on the phone. We are not going to need you. And I just actually got the same note. And the same for you, Ms. Hoshu. I think we have exhausted your time for this evening. So thank you so much.
To do.
Thank you so much to both of you for being here for as long as you have been. It is appreciated.
Thank you. Bye-bye.
Thanks.
Thank you.
Okay, so Mary, do I need to propose that we amend Mary's motion, or can Mary propose that we amend her motion to see that language, and then I can second it so that we can be dealing with the amended version and not the original version?
My opinion is that we're in so deep on the amendment that there should be an amendment first, voted on by this board, and then the actual motion.
Right, that's what I'm saying. Okay, are we clear on where we're at with the amendment?
I would like a recap of what we're voting on right now, please.
Okay, so Mary, do you want to propose this is your proposed amendment?
So my proposed amendment is that the last sentence in the first paragraph reads, the mitigation measures below go into effect January 3rd, 2020, with the exception.
2022.
2022.
2022.
It just feels like we're still in 2020.
Thank you. With the exception to delay implementation of the mask optional protocol
until January
18th, 2022. Secondary. So with the exception of a delay in implementation of mask optional protocol at the secondary level until January 18th, 2022.
All right, I'll second.
Can I confirm for my own understanding on this vote? Beginning on January 18th, there would not need to be any additional action by this board for masks optional to go into effect pursuant to the 3% safety net we've already included in this bill.
Correct.
That is my understanding.
I'm seconding. Okay, so now we vote on the amendment.
While we're addressing this plan, I hate to put a kink in it. You guys can decide how you want us to handle this, but since we adopted this, it addresses test to stay every day, and the county health department has given us clearance to do test to stay every other day. So I was planning to correct that on Monday with any CDC guidance. So are you okay with us waiting till Monday to correct that, or do you want to correct it today? Do you want to correct it today in this motion?
I'm fine with correcting it on Monday.
Perfect.
Just because we're in the weeds, but I know that we need to keep going down that path. But if somebody feels the need to do it tonight, we can.
I'd rather do it on Monday so we know we have it right. And when we bring this motion that you approve tonight on Monday, hopefully we don't miss anything, but I just want to make sure we have it right.
Okay. So let's just run down the row. This one we'll do voice vote. Terry, will you roll call it for us?
Yes.
No?
Yes.
Yes.
No.
Yes.
No.
Okay. So the amendment passes, and we're now going to need to take a vote on the amended version as to whether or not we pass it. And I think this is the vote that was requested that we do via paper ballot. So just write your name and your vote on the ballot, and we'll pass it to Terry, and she can read it.
Okay, can you repeat what this paper ballot is about? Because it's hard to hear some of the conversation if people aren't speaking directly into the microphone. So I apologize. Thank you for your help.
Sure. So there was a request from a board member that this vote be recorded via paper ballot so that people could vote how they wanted to vote, perhaps without hearing how other people were voting. So we're putting it in paper to provide to Terry, and then she will read it all at the same time once they've all been turned in. And I know that as you are remote, that this makes it a little bit more difficult, but if you can just email your vote to Terry so that she can read it, that would be fantastic.
Yeah, so
Okay.
Absolutely. Thank you. What specifically are we voting on then?
Okay, so I'll have Mary read it one more time for fun.
So, is it the same vote? We're just
It's
putting
the
it on
same.
paper?
It's the same. What we just voted on was to amend her original motion, which was to delay the
Okay, got it.
implementation. And so we're not delaying implementation anymore. We're just altering the implementation.
Okay, thank you.
And Mary, if you want to read it one more time, just for clarity's sake.
So the last sentence of the first paragraph would read, the mitigation measures below go into effect on January 3rd, 2020, with the exception
2022.
2022, just checking sure, make sure everybody's awake. So, with the exception to delay implementation of the mask optional protocol at the secondary level until January 18th, 2022.
Okay.
My email has been sent, FYI. Terry, please let me know if you don't get it.
I have it, thank you.
Then,
Oh, yeah, of course.
don't forget to put your name on your ballot.
Two more.
Mary, before you read, can you give me just a second?
Yes.
I need to make sure that we address something. My question is, what does this do, and I need to find it in the document, but what does this do to buildings without kids? I gotta find the bullet and see what it is. Where is it?
Is that the tortillas that you have, like, on?
Yes. Yeah, but that's. So it's not in here, and I'm assuming that's because nobody was masking, and so we didn't need to address those buildings.
Okay. So it's not an issue at this juncture?
Actually, I think it is, because if I'm if I work at, let's say, O&M, nowhere in here does it say I have to wear a mask. So do I or do I not? As long as I'm not in a school, that's not here. In the previous document, it was addressed, because there were buildings that had, everyone had a mask requirement, so we had a mask requirement across the board, right? With this, if you walk into an elementary school, you're putting a mask on, but if you walk into a high school, and I'm an O&M worker, I wouldn't have to.
If you're an O&M worker walking into a high school, you wouldn't have to put on a mask?
Not after January 18th, I wouldn't.
But if they're walking into the high school building, the policy says that they have to, visitors are welcome in a limited capacity, but they have to, all visitors must follow the building mitigation protocol.
So I guess they're not technically visitors, they're employees, but I guess, does this include all employees in all buildings? Does your,
Well, if we do this update that we voted on, can we come back and address employees and vote on that separately?
yes.
Add to this, if memory serves, I believe in the previous one, the language was the building where students are. There was some language that talked about, and again, I don't have it in front of me, but I remember that it was, because we were wondering about this facility, this building, and we were wondering about, well, if we're here in the evening and there aren't any students here, did that apply? But
I think it was all facilities, because I know O&M have a mask requirement right now, or did up until today.
Okay. Well, why don't we, Dr. Ziegler, did you have something to add?
Yeah, if you go back and look at the August document that we were under, it was in the opening paragraph of the document, so it was in the top section, not addressed specifically as a bullet. So the document previously read, will require masking of all children and adults in grades pre-K-12 in all district facilities until further notice.
Okay. And this one does not say in all district facilities. Is that the difference? Well, let's see where we're at with this one, and then we can address this issue with regards to O&M and other district facilities.
You ready? Ms. Borgman voted no. Ms. Goodburn, no. Ms. Hembry, yes. Mr. Stratton, no. Dr. Sinclair, yes. Ms. Owsley, yes. Reverend Guy, yes. 1, 2, 3, 4, 4 to 3 passed.
Thank you. Okay, so we need to clean up whether or not this applies to all district facilities.
Is this a cleanup that's necessary because of the amendment the motion that just passed, or would it have been necessary regardless?
It would not have been necessary regardless, because the elementary in the current document, in the January 3rd document, it's clear that masks are required for all students and staff in that building. And so with the change of secondary going back, it only addresses schools.
Mm-hmm.
And we wrote it that way because of, it worked the way it was until we made the amendment.
Okay. So do we need to have a motion to include all district facilities in a second? Or if there's a counter motion to say we don't need to include facilities that are only staffed by adults, or how?
I think in the previous, we said when children were, anywhere children are present.
Anywhere children are present? So do we need an amendment? I'll propose an amendment to adjust the first paragraph. Right, it's a new motion. I'm making a motion to add a sentence to the first paragraph that the mitigation measures are effective anywhere children are present. Any district facility where children are present? During the school day? Yeah, I mean, I feel like any building, any district building in which children are present would probably get the job done, I think.
I'm just thinking vacation, sporting events.
I would suggest, I'm going to be honest, I don't really like this, but I would suggest for the sake of cleaning this document that we just say we're universally masking until January 18th. And here's why. Because if we say when children aren't present, that means on February 18th, well, I guess it goes into effect then. Tomorrow, for example, no children are present. So PD all day, no one has to wear a mask if they don't want to.
Okay.
Written that way. No one in this building would have to wear a mask as written. So for the sake of clarity, and if we're only going till January 18th, I would say universal masking.
Okay. So where would we, can I see your motion, where we'd be inserting universally masking?
I think you could just add it, have us add it to the opening paragraph.
I'm sorry, what?
I would just add it to the opening paragraph as similar to what we did in the previous one.
Okay, so I'm sorry, I'm trying to follow. I can't read Mary's writing. Mary, can you be the person who makes this motion?
Okay, so, I'm sorry, Dr. Hubbard, I'm looking to you for like I know
I know, so the mitigation measures below go into effect on.
We're just adding
Sorry,
Can I?
Space, I'm just trying to read your thing.
This feels super messy. Is it possible for me to make a motion to stick with the mitigation measures that we approved on November 15th? That we have right here in front of us? It seems like there are a lot of intertwined parts here, and changing just the one thing is not nearly as simple as we would like for it to be. And the underlying document is very close to very good.
Well, I think we can do the universal masking issue and then address that 2-week window and address the concerns that have been raised by.
It feels very
The
messy
medical
to be making
professionals.
these changes without our administrative team having recommended them to us. So if I made that motion, would there be a second?
I mean,
If you
Brad's
repeat
our
the motion,
parliamentarian here.
Jessica.
You have to make a motion.
I would like to make a motion that we continue with the mitigation measures in front of us effective January 3rd, 2022, that were approved originally by this board on November 15th, 2021.
So point of clarification, we've already passed the amended document. So we can speak to the amended document, but I don't believe we can go back and speak to the previous. So just want to make sure that's clear, that we've already passed the amended now.
right.
But again, we can add to it with new motions. It's a little trickier to unwind something we already passed.
Right. if we add universal masking to this, we've addressed the concern with regards to the additional facilities. I don't know that.
I think, I'm going to be honest with you, I think the answer is yes. Looking to all of you to be meeting with me right now to make sure we're not missing something, but I agree with Jessica, it feels really messy. Just to be honest, when we would amend a document like this, it would take us 2 or 3 days just to make sure we're not missing.
Mm-hmm.
So that's my biggest concern at this point.
I think
Dr. Stubblefield?
I think the other concern would be if we're going back to universal masking for all of our buildings. Now, what does that do for the things that we've said that you don't need to mask for all of our activities and athletics that we've already said? You know what? You don't need to do that.
But that doesn't impact the CASHA portion because the CASHA was separated out.
Okay, it was in the document though.
Mm-hmm. But in the document, it says that we're following CASHA guidelines for the extra activities.
I also wonder what it does to our winter guidance document. Pull that up.
Well, I'm reading this under activities and athletics. It says all schools will follow CASHA and district guidelines. How do you do both?
And we are going to have to go change the winter mitigation plan as well.
Mm-hmm.
Because of the way it's written.
Well, we've had a difference in the CASHA guidelines and our school day guidelines for the last.
Since the beginning of December.
Yeah, so, I mean, so that's not.
But hear me out for a second. On November 15th, the winter guidelines, which we link to, says secondary schools masks are optional indoors.
It's just the policy, it's not, it's the effective date. So it still reads, because the effective, I'm sorry, may I?
Yeah, go ahead.
So the effective date is only listed once, and then all of the language follows. So CASHA rules were separate. We adopted CASHA rules effective December 4th or something like that, I believe. They went into effect. So, you know, the policy stands in place. We passed it back, you know, November. We're just changing the effective date before kids come back to January 18th. I'm sorry, I wasn't following you on the language we needed for adults in buildings with no kids. I'm sorry, I was struggling to recall the language you were using. Mm-hmm. But I understand too that being able to think through this with clear mind is also very daunting. So, and the care with which you all have developed plans is significant. We also have.
So we're okay. I think we're okay on it.
Dr. Hubbard, is it as simple as if the interpretation is that the board just passed universal masking across all buildings until January 18th? I mean, is it that simple? Do we read it that way? And does that clean up everything?
Yes.
Does that give us the guarantee, though, that after January 18th, we go back to this 3% safety net? Because I think it would then require another vote of the board.
No, because the January 18th is when that requirement drops, and the rest of it remains in place.
We can state that too, though.
So I think the amended document as stands is fine, but it needs to be amended one more time to address universal masking in all district facilities until January 18th as well. So maybe after the initial sentence where we say we're delaying secondary mask protocol to January 18th, 2022, we would also say, additionally, universal masking will be required in all district facilities until January 18th, 2022.
Okay.
I would like to make a motion to return paragraph 1 to just say that the mitigation measures below go into effect on January 3rd, 2022, so that what we have matches the document that is in front of us. I feel like amending a document like this on the fly when it would typically take our administrative team days to review puts us at risk for a lot of unintended consequences that I'm not comfortable with. So my motion is to revert back to the last sentence of paragraph 1 reading, the mitigation measures below go into effect on January 3rd, 2022.
Can I ask a question before we look to see if there's a second for that motion? If we paused where we're at to give the administrative team time to look at this tomorrow, because students aren't back in the building until Wednesday, and we looked at it after they had an opportunity to update it to see things were uniform, would that be something that you would be comfortable with? Like, could we, my concern is that we've got kids coming back in the buildings on Thursday for all the reasons that were just listed. Wednesday. All the reasons that were just listed by Mary's motion. To scratch all of that, this is messy. It is. The entirety of this experience right now is messy. So how do we address this in a way that reassures folks that we're going to have the data we need to implement this successfully?
I want to get clarification as well, and that is the motion to revert back to this document as it stands with no amendments made? And I will second that motion.
Okay. I'm going to guess we can voice vote on this unless there's another amendment. So Terry, if you'll roll call it, let's roll call it.
I just want to clarify and make sure, can we just repeat specifically what we are voting on?
So Jessica made a motion to revert back to the initial document without the amendment.
So does that make the January 18th vote null and void?
Correct. It would undo what we just voted on.
Okay.
Okay.
Got it.
Okay. Reverend Guy,
No?
Mr. Stratton,
Yes?
Dr. Sinclair,
No?
Ms. Owsley,
No.
Ms. Goodburn,
Yes.
Ms. Hembry,
Yes.
Ms. Borgman.
Yes.
Okay, 1, 2, 3. Ayes have it, 4-3.
Okay. Well, I think we don't have any further business at this time.
I do want, I'm sorry, I don't think we should talk about it tonight because we've been here for 3 hours, but I believe strongly that vaccinations hold the most promise for arriving at the place that I think we're all trying to get, which is consistent schools, open and operational for our families. And if we could spend a portion of the time that we've spent talking about masks, talking about a vaccination requirement for our staff, our community is counting on our schools to be open, and they are counting on teachers to be in our buildings for their families, for our families. So I would love us to return to that conversation at some point in time, because I think we're going to be on this roller coaster for a really long time until we get to a point of more vaccination. I think about how much time and energy we've put in on EAPs and wellness clinics, and then to have this incredible life-saving tool in front of us that we are not necessarily doing anything to promote amongst our staff feels like a real missed opportunity to me.
I would
Dr.
just
Hubbard?
like to clarify, I do think we're promoting it, and we are providing
you.
clinics.
Fair,
So,
fair.
okay.
Okay. Well, unless there are any further motions? Seeing and hearing none? Seeing and hearing none, we are adjourned for this evening. Thank you.